Welcome back to Long COVID Doctor, an educational series for all of you out there who still have long COVID. I'm Dr. Tim Robinson, formerly a family doctor, a GP for 30 years, and now working in Long COVID Services for 5 years. I post on all the usual podcast channels and also on YouTube. So I hope you find these posts helpful. If you do, please click subscribe and spread the word. Just to say that there's no conflict of interest here. I do this for free. I'm not getting anything from this financially. My reward is really, long and short, is to get you better, to help you in your recovery from long COVID. So there we go. Thanks for all the feedback you send in. Really appreciate it. Apologies, no replies, no time. I wish I could respond to all your queries and comments, etc., etc. But like I said, really, I haven't got the time to do that. But please keep them coming because I find them really helpful. It helps me, guides me for future postings. So another apology, my usual disclaimer, and it's important, of course. Any advice, treatment that I mention in this podcast or other podcasts, please, should only be taken and after talking to your own GP, family doctor, etc. So here we go. This podcast and YouTube post is basically all about low dose naltrexone, LDN. So here we go. Topics I will be covering are basically what is LDN, low dose naltrexone, why should we be using it in long COVID, how does it work, the evidence, and then the more practical side like the dosing and sort of also the safety elements, etc. So let's make a start. What is low-dose naltrexone? Well, basically it's in its title. LDN, low-dose naltrexone at a low dose. Low dose. Okay, not the standard dose. So what is the standard dose? Basically, standard dose is 50 to 100 milligrams for a specific purpose, and that is it's an addiction medicine. It's to help for people who have been addicted or are addicted to opiates, so morphine, codeine, oxycodone, etc., but also alcohol, to help them in the process of coming off their addictive substance. Okay, it's to prevent relapse. So that's the standard dose, 50 to 100 milligrams. So a low dose is basically a tenth of that quantity, that milligram. So it's 0.5 to 4.5 milligrams. That's the low dose. Low dose. Why a low dose? Well, because different doses have different effects. At high dose, naltrexone blocks opioid receptors. At low dose, naltrexone blocks inflammation. So let's talk about it a little bit more in depth. Okay, naltrexone and low dose naltrexone. What are they actually used for? Like I said, naltrexone standard dose is used to help people come off their opiates and alcohol if they're dependent on it, they're addicted to it, and it prevents them, it's prescribed to prevent them relapsing and taking up their habit again, okay, after they've withdrawn. Whereas naltrexone at the low dose is used off-label, okay, outside the license, okay, for chronic pain and neuroimmune disorders, and it has been for many years. Why should we be considering LDN in long COVID? That's the question. Well, let's remind ourselves, not that we really need reminding, the main symptoms of long COVID are fatigue, brain fog, pain and headaches, sleep disturbance, and Underlying causes are neuroinflammation, inflammation of nerve tissue and many other tissues, of course, and also immune/inflammation dysregulation. So that's what we've got on our plate for long COVID. Well, remember that low-dose naltrexone before the pandemic, pre-COVID, has been being used off-label for chronic pain. Hello. You get that in long COVID, don't you? And also neuroimmune disorders. So inflammation in the inflammation and immune problems within the neurological brain tissue area. So therefore, LDN may well be of use in long COVID. Let's look a little bit deeper into the mechanisms of how low-dose naltrexone works. Well, there are three sort of key mechanisms. The first is it brings about what we call an endorphin rebound. Okay. Using naltrexone at a low dose very temporarily blocks the opiate receptor. Okay. It then wears off and triggers a rebound increase in your own natural endorphins, your own natural opiates, your own natural painkillers. So it boosts your natural painkillers in you. So therefore, theoretically, it could be useful in long COVID pain. Yes, and particularly neuropathic pain, as in nerve pain. Second mechanism is its anti-inflammatory effects. LDN may reduce the activity of the brain's immune tissue, its microglial cells, okay? Its own brain lymphatic tissues, its glial cells. The tissues, microglial, are the tissues that basically fight infection, fight inflammation. And therefore, there is potential reduction in the inflammation within the brain tissue, within the nerves, within the brain. Okay. So reduced neuroinflammation. LDN also reduces the inflammatory cytokines, those inflammatory mediators like IL-6, interleukin 6, and TNF alpha, and interferon gamma. It reduces those inflammatory cytokines. And finally, it reduces oxidative stress. Oxidative stress, you remember, free radicals, these sort of these what we call reactive oxygen species that are released in everyday metabolic function within every cell. The byproducts, or the sort of, if you like, the rubbish left behind, is mopped up. Okay, so LDN can reduce that impact of those free radicals and reactive oxygen species. There's less oxidative stress, which is good news because oxidative stress causes damage in cells. And then finally, there's the effect of LDN on the immune function. It serves to rebalance the immune system. It reduces immune overreactivity. It just calms it down. It also has potential effect on mast cells, which we know, remember, mast cell activation, part of the excessive inflammatory response that is experienced throughout the body in long COVID. So what are the benefits of LDN in long COVID? Well, it reduces fatigue. It can reduce brain fog. It can reduce pain and headaches. It can improve sleep, and also improve sort of everyday daily functioning, activities of daily living, as we call it. So those are all the potential benefits as a result of those mechanisms that I've just underlined. outline, sorry. Okay. It's sounding theoretical. Is there any evidence, you're asking? Yes, there is. There have been a number of studies, which is very comforting, reassuring, that demonstrate that LDN makes a difference and brings benefits, brings improvement. Okay, they're mostly observational studies. That's like observing a group of patients who have been given taking LDN, and and seeing how they respond. So you're observing the patients. Evidence-based medicine, really, the gold standard is a randomized controlled trial, of course, and that's basically when you take a group of patients and you divide them to one half gets the drug you're testing, LDN, and the other half gets a sugar pill, a placebo. And after a period of time, each is asked, how do you feel? Is your pain better or worse or exactly the same? And so that's a randomized controlled trial. And that, as I say, is the gold standard in evidence-based medicine. Well, unfortunately, there aren't very many RCTs, randomized controlled trials, for LDN. However, there are a few low number trials with a very small number of patients that demonstrate these RCT trials that demonstrate an improvement in fatigue and fog and brain fog and pain and sleep quality and quality of life overall. So that's good. We of course want big trials. We like big trials, big numbers. And there are a couple underway, one in Vancouver at the moment, and also another in America, a part of the Recover trial, which you might have heard of. One limb of that massive trial is looking at and giving patients LDN. So we're all waiting anxiously and expectantly for the outcome of those two big RCT trials. And I say expectantly because we really, based on what our patients are telling us, and also those small RCT trials, it's, I think, promising. So that's the evidence. Those are the mechanisms, the evidence, and the reasons, the rationale behind taking LDN in long COVID. Let's now turn to sort of the more practical side, the dosing strategy, etc. How do we go about taking LDN, low dose naltrexone? Well, like anything, as always, start low, go slow. Well, it is low dose naltrexone already, so start low, but go slow, in the sense of start at a low dose, so 0.5 milligrams, and basically take one of those every night and then go slow. So don't increase it sooner than 2 weeks. So after 2 weeks, you've got 2 weeks just to get used to it and, to see whether there's any improvement and to make sure there's no side effects and feel comfortable with that. And then at that point, if it's not made any difference, it's not improved you in any way, then it's justified to increase the dose. And we can go step by step, incremental, small little steps, go slow, and up to 4.5 milligrams maximum. Taken at night, and basically it can take a few weeks for the benefits to come about. That's why I was saying don't increase the dose sooner than a week, wait a couple of weeks. may even not need to increase the dose at all because, you might have hit the jackpot first time round with 0.5 milligrams and you might not need to increase the dose. If it's doing what it's meant to be doing, as in dampening down pain and helping with brain fog and fatigue, etc., actually, you don't. Let's not be greedy here. And why increase the dose when you don't need to, when you've achieved what you want? So you may only need that 0.5 milligrams. Our experience is that there's a sort of a range, that range 0.5 to 4.5. Patients, are scattered between those two levels. And then, if you're stable on it and, happy days with reduced symptoms, etc., you can stay on that. Should be reviewed, of course, after 8 or 12 weeks to make sure that everything's going all right, there are no side effects, and to check that there isn't a need to increase or indeed decrease the dose. So it can be taken ongoing, like I said, as long as it's reviewed and any responsible practitioner, GP, family doctor, neurologist, specialist will want to or should review their patients. But as long as the patient is getting regular reviews, it is reasonable to continue with this. And we've got patients who've been using it now for quite considerable time, year, 2 years. Certainly outside of the long COVID context, like I said, it's been used in other conditions. I'll come on to that a little bit later, but it's being used, by patients for long periods of time. So there we go. How is it taken? Well, basically it's taken either as a capsule or a liquid, and there are also sublinguals, under the tongue, formulations where it basically goes straight into the bloodstream when the preparation is sucked under the tongue, and it is a medicine that has to be specially sourced in pharmacies who are familiar with making up medicines. You can't just take your standard dose of 50 milligram tablet that's used for standard naltrexone dose for the addicts. You can't just take one of those tablets and just chop it in half and then quarters and then eighths and sixteenths, because you're not going to have a precise enough measure and quantity. You can't be sure that you're getting 0.5 milligrams or 4.5 milligrams, whatever dose you're on. So there it is. Safety overview. Well, generally it's very well tolerated at low doses. Side effects are uncommon, only mild if they do occur. So serious adverse events are extremely uncommon. Great peace of mind there. What are the side effects? Well, basically the side effect that is heard about more often than anything else is the vivid dreams and sleep disturbance, or insomnia, not being able to get to sleep. Sometimes patients complain of a headache and nausea. Some patients, when they're initiating the LDN, can have a bit of a flare-up of their symptoms. It's only brief, it's only temporary, but I think it's not severe, it's only mild, but it's certainly something that we hear of from time to time. The only side effect that's on the list, if you like, is when naltrexone is taken, not low dose naltrexone, when naltrexone is taken at a mega high dose, so 300 milligrams. So that's well in excess of what it's normally taken for when it's used for standard dosing. So 300 milligrams can cause liver problems. But we are talking here low-dose naltrexone. So you can have liver problems at 300 milligrams. But actually, remember what I said? We're only prescribing up to 4.5 milligrams. Specialists can go up to, up to 12, I've heard of. But on the whole, it's 4.5 milligrams. So there's no way 4.5 milligrams is going to cause liver problems. I think the other thing to say is those small, those trials in which LDN has been used, those random controlled trials, they did not report any serious adverse effects in the treated group compared with the placebo group. So that's a tremendous comfort and reassurance. So we've done safety. What about drug interactions? We should always think of potential drug interactions. If you're on a pill already or tablet or whatever for other conditions, blood pressure or, migraine treatment or something, or asthma or any drug, we've always got to have that in mind when you're introducing another drug, because we don't want the drugs to clash. Well, basically, again, it's pretty innocuous. It's something that doesn't have many drug interactions. Obviously, if you're on an opiate, such as codeine or an opiate derivative of codeine or oxycodone, tramadol, for serious pain relief, then that could interfere with taking naltrexone and bring about a sort of enhancement of those opiates, and make them less. When I say enhancement, it's sort of it enhances the naltrexone effects, but it can reduce the pain effectiveness, pain suppression of those painkillers. Essentially, it's like I said, any new drug, you must, when you're prescribed, you must always make sure that the prescriber considers other medicines that you're on at the same time, so there's no clash. I'm sure they will. Any groups of patients that we've got to be a bit cautious about with LDN? Well, pregnancy and breastfeeding, we tend not to use it in those groups, those patients, because, well, there's limited safety data, but actually it's probably completely harmless. But because there's limited safety data, we can't hand on heart say, actually, it's entirely safe. So it's always best to err on the side of caution and not prescribe when we're not entirely sure. Liver disease, if you've got serious liver disease, remember, these high doses of LDN can cause liver damage. But again, these are rare cases, and, you're probably not going to encounter many patients who have serious liver conditions and who need LDN. Again, we're just being ultra cautious here because it's LDN, low dose naltrexone, so it's probably not going to make any difference anyway. So, I've talked about LDN for the use in long COVID. What about LDN in other conditions? I was mentioned earlier that, yes, we've been using LDN in other conditions before the pandemic, before COVID, for many years. And the two conditions that sort of have similarities with long COVID, it's not the same, but similarities, similar features, if you like, are ME/CFS, so chronic fatigue syndrome, myalgic encephalomyelitis, and fibromyalgia. So the specialists in these fields have been prescribing LDN for those patients for many years. I say in a number of years and many years. And there are studies. They've done studies, random controlled trials on those patients for LDN. And the evidence is, out of those studies, is that it helps with fatigue and brain fog and pain. So, because of the similarities between the fatigue, say, of chronic fatigue syndrome and the aches and pains, muscle pains, etc., of fibromyalgia, the similarities of those symptoms with the same symptoms in long COVID supports the rationale of using LDN in long COVID. What about other conditions besides ME/CFS and fibromyalgia? Well, LDN has been used for many years pre-pandemic in conditions such as multiple sclerosis, Crohn's disease, rheumatoid arthritis, complex pain, regional pain syndrome, neuropathic pain, plus also cancer and HIV. So, it's not a totally new, unique medication that is new on the block and it's never been used before. Yes, it has been used. There's already a lot of experience and benefit demonstrated and supported by evidence-based medicine trials to say that LDN can help with many symptoms in many conditions, and why not long COVID as well? And let's get back to our patients. What are our patients saying? What are the patients who are taking LDN saying? Well, for a lot of patients, they're saying that it's, given them tremendous relief in a number of their symptoms. Like I've said, fatigue, brain fog, pain, improve their sleep, improve their quality of life. But it's not for everyone. There are also a number of patients who tell us that actually it's not made any difference at all. So, it's a case of suck it and see whether it helps. If it does, fantastic. You've got, you've got some symptom relief. If it's not made any difference, well, stop it. So that sort of almost brings me to the close. Basically, let's think about the key takeaways here. Well, LDN is a promising off-label option for many symptoms in long COVID. It's generally well tolerated. It's safe, low side effect profile. Careful dosing is important, of course. Remember, start low. It is low dose naltrexone. Start low, go slow. We need more studies. We need more evidence, and it's coming. Just hang on. Remember what I said. Those 2 studies that are sort of in play at the moment, and hopefully we'll get some results soon. I think finally, I'd just say this is a symptomatic treatment. It's to deal with symptoms. If only it was a cure. It's not a cure. We're still looking for that, searching for the holy grail of long COVID, the cure to the underlying cause. But this is purely a symptomatic relief. It helps with quality of life. So there we are. Good. That is LDN, low dose naltrexone in long COVID. And I hope you found that helpful. As I said at the start, my usual disclaimer, advice on LDN and any other treatments I mentioned, both in this podcast, YouTube, as well as others, discuss with your doctor first. Remember, safety first. If you have found this helpful, click subscribe. I said that at the beginning, didn't I? Spread the word. Let's get it out there. Thanks for the feedback. Again, I'm going to repeat myself here. Apologies, no replies, no time. Keep them coming, though. I appreciate them. They help me with my future postings. In the meantime, I wish you well with your recovery. And until my next posting, all the very best. Cheerio now. Bye-bye.